Good afternoon, class. I'm going to spend a few minutes. We're coming up on our first quiz for the health econ class, and I thought I'd spend just a few minutes trying to at least outline what I think are the salient points of we've read Era's article. I presented some just broad-based notes about medical economics or healthcare economics. And then we jumped into Dewar's text. She talked about issues with the American healthcare, or the U.S. healthcare system. And then she also talked about the role of economics in her second chapter. So I've made some notes and kind of going through that. Not necessarily, I'm not sure, I haven't written the quiz yet, but the quiz more than likely will come from some of the notes that I'm going to go through here in a few minutes. So we're going to jump in and start, and I'll be looking back and forth just to make sure I don't miss anything. But Errol's article, again, as we talked about when we went through the article, academics will somewhat consider it's the seminal article, and with changes in healthcare, it was produced or actually published in '63. My guess is he probably started writing it sometime in the late 1950s, maybe the early 1960s. I just at that point don't know how long it took him to get his article published. But again, he publishes this article in 1963, and from there it kind of snowballs, and then we start getting Medicare and Medicaid enacted in '66, I believe. You had TRICARE in '67. So kind of jump-started a lot of the programs that we now see, especially on the kind of the welfare economic, social economic side of the house. So, and he talks about in his article, as he starts off, he talks about normative, and that's more along the lines of, social economics, policymakers, government officials. Normative talks about how things should be. And if you're an economist, you're using positive comments, because here's how it really is. So that's where he's comparing normative and positive together or against each other. And he spends a lot of time talking about uncertainty in medical care. And that's what his article was about, is how uncertain and risky that medical care is. It's the incidence of disease. You never know really when it's going to occur. I mean, yes, there are models that can predict the number of individuals that are going to have the flu, say, from about November of any given year till March or April of the next year. Models that can predict asthma, pollen, allergy issues, typically in the spring in most areas in the United States. At least models that can guess at what the incidence of heart issues, heart disease is, as in certain age, sex demographics. So there are some models out there, but for the most part, the incidence of disease is somewhat of a random event. And then the second piece of his uncertainty is the efficacy of your treatment. When you walk into the doctor's office, and I'll get into it a little later, but when you walk in the doctor's office, at least from my perspective, it is somewhat of a crapshoot. You've selected your doctor based on maybe because he or she happens to be in the network of the health plan that you have, or you've done some work on the internet and you've decided, well, they went to medical school here, or they did their residency here, or their intern here. So there's some pieces of information you have when you walk in. But there's always that uncertainty on what the efficacy of your treatment plan is going to be. When you walk out of that visit with the doctor's office, or when you go in, especially to the hospital for that surgical procedure, you don't know exactly what the outcome is going to be. So Errol bangs on this constantly in his article. Uncertainty, risk, it's just I don't want to say the backbone of his article, but he tries to lay it out for you. And again, this is in 1963 when he's laying it out for you. His vision, or his view of what medical care was and the issues with medical care in this 1963 article. And he talks about risk versus uncertainty. And if you've taken some finance classes, they will talk about risk versus uncertainty, that information transforms uncertainty into risk, and risk is somewhat manageable. You can assign probabilities to risk. You can develop and implement strategies to manage risk, but it's the uncertainty that causes the greatest angst when it comes to medical care. And it doesn't matter what's in the United States or other countries. There is just an angst associated with walking into a doctor's office, walking into a hospital to seek medical care, because there is such uncertainty with the outcome of that treatment. And Arrow also goes on to say that there is a cost information. And I can get on the internet, I can go to Google and I can start searching the internet for information about a particular potential diagnosis that I think I have. I can go to WebMD. There's a lot of websites out there that you can access, and you can build a profile of bits and pieces of information. And unfortunately, as you're surfing the internet, or if you're at the library looking for information, there's a cost associated with that information. And at that point, you're turning information into a commodity. So, and Ayer also talks about turning information into a commodity, and that's based on the cost of information. He also talks about asymmetric information. You're a patient, you have a small piece of information. You go in to see your provider, and at least in theory, the provider should be exponentially more informed than you are as a patient. Whether that's actuality, reality or not, it varies based on whoever your provider is. But in theory, at least they should, because they've gone to medical school, again, maybe a residency or an intern program. And so they should be much more versed in how to diagnose your malady, and then how to treat your malady with the highest probability of a positive outcome. And then Arrow also, kind of flips it. And when you're looking at the provider side of the house, there is, when they're trying to estimate demand and, how to build out a practice. And he even talks about, demand is irregular, it's unpredictable, and it's risky. So while it's uncertain for you as a patient, it is as uncertain to the provider or a medical group as they're trying to build demand models and trying to estimate what demand for their services are going to be, not only on a given day, but in the next week and in the next month and the next year. And that I guess where he's trying to go, or at least where I think Arrow's trying to go, as he gets into medical care, it's a product. It's uncertainty. You don't know what the quality is. Again, it goes back to how well your provider's been trained, and so it's not like you can go into your local car dealership and take it out for a test drive or kick the tires on it. You don't have that luxury, because in many instances, when you go in to see your provider, it's a one-shot deal, and you have one shot or one chance to get it right. It's not like you can test drive the product or kick the tires on it. And if they miss and the treatment goes south on you, sometimes the consequences are dire. And it is just from a patient's perspective, it is extremely uncertain when you go in to see your medical provider. And again, it's based on asymmetric information, a level of information the patient has, a level of information the provider has, and also, and what a lot of people don't think about, and Arrow gets into it to some extent, there are the financial incentives, and how the financial incentives with that provider align to incentivize them to try to provide you with a treatment plan that generates the most positive outcome for you, the patient. And lastly, Arrow down at, in multiple places in his model, he talks about a competitive market. And again, if you go back to your old economics, especially your microeconomics, what is a market? It's just an organization that brings buyers and sellers together. and it provides them with an opportunity to either buy or sell, goods or services. And that's exactly what health plans do. They're a market. And Era gets into, here's the healthcare market. And he starts going down through and trying to lay out why in some instances it is similar to a competitive market. And in other instances, it may not be similar to a competitive market. And if you, again, go back to your old micro theory classes, and, we talk about a competitive market, there's a large number of firms. Then just look at it, okay, for the most part in the United States, if you live in a large urban area, I live in Atlanta, a lot of you as students, you may be in, Nashville or some other large suburban area. There are a large number of firms, large number of doctors' offices, large number of hospitals, large number of pharmacies, large number of ancillary providers with which you have to pick and choose from. And because there are a large number of firms, it makes the assumption that there's a large number of buyers and sellers appropriate when we're looking at the competitive market. And then another assumption in the competitive market that somewhat holds true for healthcare is that the buyers and sellers are looking at goods and services, and they are homogeneous goods and services. And in theory, a doctor's visit is a doctor's visit. A trip into the hospital is a trip in the hospital. Trip in the emergency room, urgent care. At the base component of that, it is a homogeneous service. Now, I would definitely argue with you that because of quality and other factors, it's not homogeneous. But in the essence of microeconomic theory, or just economics in general, we're trying to simplify an extremely complex world. And for that reason, we make the assumption it's a homogeneous goods and sellers. To me, where it starts to really get tricky is it talks about in a competitive market, it's easy entry and easy access. I'm not sure outside of certain areas within the healthcare market space or in the medical care market space, I'm not sure it's easy entry. If you want to be a physician, you've got to have an undergraduate degree, you've got to have a medical school degree, residency, internship. In most cases, you have to have that. If you want to be a nurse, you have to, most medical providers or groups or hospitals would like to see the nurse have a 4-year, Bachelor of Nursing degree. If you want to be a nurse practitioner, you've got some additional schooling to go to. But it's not that easy to get into, probably fairly easy to exit, but trying to get into the healthcare market, it's somewhat, especially cost prohibitive, but it's not what I would call easy entry. And then lastly, it talks about the assumption on a competitive market is complete information about prices. And there's definitely not complete information about prices. To me, that's where the wheels really start to fall off. Because in healthcare, unfortunately, it's not a consumer-driven, it's not a consumer-centric or consumer-driven market in terms of information. You talk to the average individual out on the street and they say, okay, you're going to the doctor's office today. What's going to be the cost? What's going to be the price? And they're going to, 9 times out of 10, they're going to give you whatever their copay is. I've got a $10 copay in my health plan. So, but, others in my health plan, they might say, well, the price that office visit is $10. Well, that's not the price of the office visit. That may be the out-of-pocket price that the consumer's paying. But the healthcare plans have negotiated prices with these providers, or the government's negotiated prices, or if you have some huge employer groups that are what you call self-insured, so they are taking all of the risk for their healthcare goods and services. So they may have negotiated some prices with these providers. So that's kind of where I see the competitive model not start to break down, but some of the wheels start to wobble anyway. And that's going to kind of wind it up with Arrow's article. And I'm going to speak just for a few minutes about that introductory article that I provided. And I guess it's out there in Module 2. And I made the comment when I with providing the notes and going through the notes, that if you take nothing away from this class, there are a couple of things to keep in mind. I'm trying to help you as a student become successful, especially as you go out into the market, especially if you decide to go into the healthcare marketplace. Trying to help you build a toolbox. And in that toolbox, I'm hoping that by the time this class is over, you're going to have some tools in there and some concepts and some understandings that is going to help you be extremely successful in the healthcare marketplace, if that is the direction in which you need to go. And one of the main concepts in that healthcare toolbox that I will continue to bang on throughout this semester is, if you're trying to do analytical work for either the provider side of the house or the payer side of the house, and you've run into a conundrum and you can't figure out exactly how to answer the question, always remember, the number one rule from my perspective is always follow the money. If you always follow the money in your analytical work, you're going to be able to answer a lot of questions. You're going to be able to provide your direct supervisor with the information they need to make decisions for either the health plan or the provider side of the house. And that brings me to the second piece of information I want you to store away in that toolbox is there is a financial coin setting out there. And on both sides of that financial coin, you have individuals that are striving to grab as much of that financial coin as possible. On one side, you have the payers. They are paying for the goods and services that are consumed in the healthcare marketplace. On the other side, you have the providers. They are receiving money, so they are generating income for the goods and services that they provide. And payers and providers are struggling, trying to maximize the side of that good or that opportunity. It's actually the sides of that financial coin that they're struggling with. On the payer side, you may have government entities with Medicare, Medicaid, VA, TRICARE. You've got private payers, individuals that may not have health care insurance, and they have the wherewithal just to pay out of pocket for it. You have, again, as I mentioned earlier, you've got ASOs, those self-insured large employer groups, and you've got health plans out there trying to provide private sector healthcare insurance. And then on the provider side, you've got medical providers, you've got hospitals, you've got pharmacies, you've got ancillary providers. And when I say ancillary providers, talking about durable medical equipment, orthotics, laboratory, radiology, all of those, I'll call them supplementary, complementary type healthcare services that are woven into your visit, either the doctor's office, maybe you're visiting the hospital. And the easiest way to understand, health economics is to go back to not only follow the money, not only understand both sides of that financial coin, but go back to your micro classes. And what are the three things that separate economics from other social sciences? And if you think about it, it's opportunity cost. It is going to be self-interest. And when I say self-interest, it's going to be optimization. So if you're on the payer side, you're trying to not only minimize healthcare expenditures, but in, let's say, the health plan side, you're also trying to maximize your profit margin. And if you're on the provider side, you're trying to minimize your expenditures, whether it's office, whether it's hospital expenditures. You're trying to maximize revenues or your income, and you're also trying to maximize profits. So self-interest and optimization is a huge factor when it comes to managing those both sides of that financial coin. And then lastly, decisions and choices are made at the margin. Margins, think about it. If you go back to your old micro classes, firms will continue to produce as long as the marginal revenue is greater than or equal to marginal cost. And as a consumer, to maximize your utility, your pleasure in seeking that healthcare service, as long as the marginal benefit is greater than equal to marginal cost, you'll still, try to get some utility out of that service. So a lot of just the underpinnings of your, health econ classes go back to your underpinnings of your microeconomics classes. And medical care, it's unfortunately not, customer centric. There is that, as Era said, there's uncertainty in price, there's uncertainty in quality, and for the most part, to the patient's point of view, those are hidden. If you're on the provider side, you know what the price is going to be, and you have an idea what your quality is, but you're probably not going to share that with your patients when they come in. And if you want to talk about, if you decide to go out into the marketplace and work on the provider side, again, go back to your micro classes. What, when you're thinking about choices in production, let's just take Meharry. Meharry's across the street from Fisk campus, and you have somebody on senior management side of Meharry that while Meharry, the organization owns the resources or the factors of production, somebody on that senior management team, CEO, COO, CFO, some acronym on the senior management team, is making the decisions on how those factors of production are combined in a production process to generate healthcare goods and services to the population that Meharry services. And again, go back to your micro classes. What are the factors of production? Labor, doctors, nurses, technicians, housekeeping, food services, anybody that anybody that falls into that labor category. You've got capital stock, and when economists talk about capital stock, they're not talking about financial capital, stocks, bonds, dollars in the bank. They're thinking about capital stock in the terms of radiology machines, laboratory machines, the Meharry Medical Center itself, that building, anything that has been produced and will turn around and be used to produce additional goods and services are considered capital stock. You've got natural resources, in which most people think of land as the most valuable natural resource. And in Meharry's case, it probably is, because if you look at where Meharry is located, probably not a lot of room to expand in that area. So they are, somewhat fixed at that point. You've got technology, and that's, economists don't think about that as, the iPhone that you're using, the iPad you're using, or the micro, the chip that's in everything. They're more, they think in terms of, economists will think in terms of technology as the technology in the production process. How efficient is that production process, and taking the inputs of production and turning them into outputs. And then last, you've got entrepreneurs. And I'm sure Meharry has some, just like every other organization does, that is, individuals that are constantly looking at ways to improve efficiency, being able to produce more with less, being able to produce higher quality with the same resources. They're always looking for efficiency. How can we improve efficiency? And then, kind of lastly, in health economics, we're always concerned about government intervention. Inefficient markets, you're always going to have government that thinks they know better than anybody else on how we should consume goods or services. It can be federal, could be state, could be local. Any government intervention. And government intervention is, you see it especially in transfers of wealth or income. You see it with, social, what they call non-market forces. So it's not really the price that's driving the equilibrium on the market. It's more or less government intervention that through laws or regulations, through price floors, price ceilings, that they call non-market forces that are trying to drive the healthcare market toward equilibrium, the equilibrium price and the equilibrium quantity. That takes care of that little group of notes that I put together, just kind of randomly pulling information from my experiences in the healthcare market. And then we're going to jump into Diane Duar's first chapter, where she talks about issues with the U.S. healthcare system. And right out of the gate, I mean, actually, when I think of issues with healthcare system, it's kind of hard for me to know where to start, because there are so many, from my perspective, so many issues with the U.S. healthcare system. But Diane just jumps in and, she talks about her, one of her, first comments, it's a dysfunctional healthcare system. And she's right. There's no central government, agency that's kind of managing the process. It's market driven. American Medical Association tries to manage or tries to dictate things with the physician side of the house. American Hospital Association, same thing with hospitals, try to dictate, CMS through Medicare and Medicaid. They're trying to make, determinations, but there is no one central governing body. So you've got those, and then if you flip to government kind of owned healthcare, you've got Department of Defense driving TRICARE, VA, Veterans Administration driving the VA hospitals. So you've got everybody trying to drive something, and because of that, there's a lack of coordination. There's the policies and procedures in place and coordinating healthcare, and you're always, anytime you go into a provider's office, there's an issue. I don't want to say it's an issue, but it's a concept that economists have come up with over time. It's referred to, the acronym is SID, Supply-Induced Demand. So you go into that doctor's office, and because you don't know what the financial incentives are going to be, you don't know whether, when he says, I want you to go for this panel of lab work, or I want you to go and get this radiology work done, or I want you to go and see the orthopod or the ENT or some other specialist. You don't know whether that provider is suggesting you go have those services, or if there's some kind of financial incentive that is incentivizing he or she to send you out for additional services when it may or may not be beneficial for your treatment plan. So, and we'll kind of get into SID later in Diane's textbook, but it's I don't know. It's always in the back of my mind when I go in to see my provider. And when she talks about the issues with U.S. healthcare system, she's always concerned about cost, quality. A, we don't know what the true cost is when we go into the doctor's office. B, we sure don't know what the quality is going to be when we come out of there. And C, there's always an issue, or there has continued to be a greater issue with access. And remember, Arrow's article was in 1963. Duar's textbook was published in 2010, I believe. So 1963 to 2010, and Duar is still hitting on some of the things that Arrow talked about in 1963. So you can kind of see the vein as they tie together. And then she, talks about, then before we get into when she talks about it's a system in crisis, just think about access. When's the last time you were able to call your physician 8 o'clock in the morning and say, I feel really bad, I need to get in to see you today? I can't remember the last time I had same-day service with my physician. I'm usually lucky if I get it with the next day. And if you call in on a Monday morning, you can forget it on a Monday morning. It's going to be Tuesday or Wednesday before you get in to see them. Now, they will typically tell me, well, you can go to urgent care if you want to. Why am I going to go to urgent care? You are my physician. I expect to be seen. I expect for you to take care of my whatever episode of care it is, and now you're starting to impact my utility function. So I'm never happy with access to my provider. And it's not just the one I have now in Atlanta. We moved here from Buffalo, New York. Same thing in Buffalo. You couldn't get in to see a physician on the same day. It just didn't happen. So access it's an issue. And she talks about, system in crisis, and the number of people, especially since, let me get my dates right, especially since 2019. So started seeing COVID pop up in 2019 and early Q1, Q2 of 2020. It was rampant in the United States. And as individuals lost their jobs because companies were shutting down, there was a decrease in private health insurance. And as there was a decrease in private health insurance, you saw a similar increase in uninsured. And Arrow saw it, 63, DeWar saw it, 2010, and now we're seeing the same thing in the Q1 and Q2 of 2020. Spiraling healthcare costs, that's been an issue for years. Coverage gaps. When you buy health insurance from a health plan and they give you your benefit booklet, you can read through that thing upside down, sideways, front to back, and it's still, you're not really sure what's covered and what isn't covered. You can call customer service, and for the most part, that individual on the customer service line can't really tell you what's exactly covered in your benefit plan. And you won't know what's covered in your benefit plan until you go to the doctor's office or you go to the hospital and try to access those benefits. And 9 times out of 10, you're not covered completely. And that's what she talks about, coverage gaps. And it's kind of one of these, surprise, you're going to have to pay out of pocket for this because it's not covered under your benefit plan. And yet again, she goes into declining access, drain on services and taxpayers. Think of all of the social and welfare programs providing uninsured individuals or unemployed individuals with healthcare benefit. And it's not only draining access and impacting the access that individuals with private insurance have, but it's also a drain on the taxpayers. And there's always this nebulous meaning of quality. And there are a multitude of credentialing agencies out there that try to estimate quality and try to serve as a benchmark for quality in healthcare, and I'm not sure any of them hit the mark. And then she shifts over to health insurance, talks about shifting financial risk, talks about the market. Again, we're going to talk about the market in her article. It brings buyers and sellers together. I usually think of the healthcare market just like New York Stock Exchange. It's bringing buyers and sellers together. Chicago Board of Trade brings futures, individuals interested in the futures markets, brings them together. And the Chicago Mercantile Exchange brings individuals together that interested in, options pricing and, buying and selling contracts. So health insurance, it's a market that's bringing buyers and sellers together, and it's like a clearinghouse. So they have contracts with the providers and they have contracts with the members, and they make sure that as you merge those two contracts together, both the members or the patients are acting according to their member contract and providers are acting according to their provider contracts. Then she talks about health status and health stock. Everybody's born with a certain level of health stock or health status. And as you grow, as you mature, as you go through your growing years, you've got individual health issues. You've got population health. Health plans are trying to help you become healthier as you go along. Smoking cessation, limiting alcohol consumption, worrying about your diet, worrying about exercise. All of that's population health, based type of information. And then you've got medical care. And if you can't take care of it through individual health activities or population health, then you can always go see a physician or some kind of a healthcare provider that's going to supposedly help you with your healthcare issues. And that's where she starts laying out her concept of health, so your health stock plus your access to the medical care or medical care space. And those two added together, generate kind of the healthcare market. So that's her approach at the way things are working in the healthcare market. And so that was chapter 1 for Dewar. And now, we're going to talk about the role of economics, or at least her view of the role of economics in health or in healthcare. And always, here's another tool for you to store in your toolbox. Economists, because we as economists, and I'm an economist, so I can make fun of myself even, but it's we as economists, we think we know everything, in which at the end of the day we probably don't know anything. But as economists, we are trying to function in this complex world. And again, it's economics is a social science. We try to follow scientific methodology as closely as possible, but we are not functioning or developing models in a lab. And so we have to develop models and assign assumptions to them. And one of the favorite assumptions of all economists is Seterus Paribus. It's Latin for all of the things equal, or nothing is changed, or everything is unchanged, depending on how you want to phrase it, or how you want to look at the Latin meaning. But they try to hold things as constant as possible. And when you look at like your normal supply, got your demand curve going down, your supply curve going upward, and that is holding everything constant but prices and quantities. And that's why we play around with the supply and demand curve. And as Arrow referenced, demand for healthcare, it's complex, it's random, it's uncertain, and it's unpredictable. And if you look at economists, or what we should do as building our economic models, as we're trying to estimate the demand for healthcare goods and services, we're invoking Seterus Paribus. All of the things equal, all of the things unchanged, except prices and quantities. So we play around with our supply and demand curves, but at some point, as we're trying especially to help not only government agencies, but health plans, or on the provider side, we're trying to help them estimate demand. You have what the microeconomists especially refer to as demand shifters, customer expectations, customer preferences, prices of related goods and services, income level, demographics, and all of those bits and pieces of information that in your normal demand supply curve we've held constant. We start to allow some of those to change. And as some of those start to change, you or myself, and I've worked in, as a healthcare economist for multiple years, we start allowing those to change. And as we allow them to change, we're allowing them to change by looking at least most of my time is spent on the health plan side, but I have worked on the provider side at the, once or twice in my career. And you're looking at, as a healthcare economist, you're looking at claims data. And within that claims data, you've got all of this information: age, sex, diagnosis codes, where the service was provided. That's a type of information that we as an economist are trying to help, whether it's the health plans, whether it's the CEO at Meharry, whether it's somebody at CMS in DC, whether it's your local healthcare provider in in the city that you live in. We're trying to help them determine who owns the resources, the factors of production, and who is the maker of the decision, who's going to ultimately have to make the decision of what are we going to produce, what goods or services we're going to produce, how are we going to produce them, whom are we going to produce them for. And you've also got this little thing niggling at you in the back of your mind is, we can't live for today 100%. We've got to keep some in reserves. So what are we going to keep in reserves? Whether it's, capital stock, whether it's, financial capital, whether it's labor, whether it's, natural resources. You want to keep some in reserve to continue to grow your organization. And again, whoever's making these decisions at Meharry is going through this on a daily basis, and they've got some economists, and they've got some financial guys, and they've got some actuaries, and these They put all these geeky guys and gals in a back room somewhere, and they are developing these models. And these senior management at Meharry or whatever, whichever firm or entity you're talking about, are hoping that the geeks in the back room that are working with all of this data and developing these analytical models are going to provide them information that helps them to make objective decisions and to keep their organizations financially viable. And so that's where we're starting to get into the role of economics. And it's both sides of the financial coin. Same thing on the health plan side. Health plan has got some analysts, they've got some actuaries, they've got some financial individuals, and they're all working together, joined at the hip. And in most cases, in the health plan side, they are under a similar umbrella, so that they are accepting the responsibility of the accuracy of their information that they are providing to senior management in order to make these decisions. So, and within the economic framework, you're bringing together, certain disciplines. You're also developing models based on scientific theory. You've got some economic theory thrown in there for good measure, and you're concerned with scarcity, because I don't care who you are, you've got unlimited wants, and you've got unlimited wants, but you've got limited resources. And again, I don't care who you are, there is some level of unlimited wants that you aren't getting satisfied. You've got opportunity cost, and when you're looking at making decisions, again, the CEO at Meharry makes a decision that he wants to expand radiology services, or he wants to expand orthopedic surgeries or services, or he wants to look at cardiovascular services or labor and delivery. And if he wants to expand those services, he has to think about what is the next best option or next best alternative, or the value of that next best alternative that he's going to have to give up as he expands these services. And that's where we're talking about opportunity cost. The economists and the actuaries are helping him make these determinations at the margin. He's making marginal analysis. But at the end of the day, he is involved in self-interest, because as CEO of Meharry, he has the self-interest of Meharry is driving his decisions, or at least what he thinks is in the best interest of helping Meharry optimize or maximize or minimize some functional relationship. And that's what's driving his decision-making process. And then he has to look at the market. And unfortunately, in most markets in the United States, we're what they call a market capitalist economy, or a free market. It's, for the most part, prices are driving everything until you have good old Uncle Sam, whether it's, it's some individual in DC at the federal government, it's some individual in Nashville at the state, legislature, it's somebody in, maybe it's in, Nashville's in Davidson County, I guess. So it's in the Davidson County area, are making some kind of decisions that's going to walk into the CEO at Meharry and say, I understand why you're doing something a certain way, but we've got these laws and regulations, and you're going to have to do it our way to a certain extent. So you've got the market sitting in there on top of this. And lastly, you've got economics or economists. They're trying to analyze data. They're trying to explain phenomena. They're trying to explain why healthcare went south and it shouldn't have. They're trying to forecast what the future is going to look like. They're trying to predict what the next new miracle drug is going to do to the covered population with which they serve. And I don't want to say it's generally fairly straightforward. It is, to a certain extent, straightforward if you're an economist, because you've got some models that do a fairly decent job of predicting. What really turns the economic process, or what keeps economists awake at night, is when something like COVID turns everything upside down. And COVID did. It just wreaked havoc on the economist approach to generating information that helps their direct supervisor, especially senior management of that organization that they work for, how it helps them function and make decisions as things move forward. And one last concept that I've actually forgotten about, and it's the concept of not-for-profit versus for-profit. So in the past, I've worked for Aetna Health Plans, I've worked for HealthNet, Centene, United Health Group, all for-profit organizations. They had equity investors, and when I say equity investors, they had, they sold shares of stock, and individuals, you had stockholders, and they were looking at earnings per share, so they were for-profit. And then I went to work for a Blue Cross Blue Shield plan in Buffalo, and they were not for profit. And one of the first days I hadn't been there, probably that first week I was there, talking to a group of individuals, group of managers that reported to me, and talking about, we need to do this, this, and this. We need to be more efficient. We need to help the government, help our organization cover costs. And I had one person raise their hand and said, well, we're not for profit. The company doesn't care whether we make money or not. And I'm thinking, what planet are you from? Not for profit is, from my perspective, it's nothing but it's a tax type of, I guess, regulation or tax constraint. It's a function of the IRS. It's a function of the way that a not-for-profit pays taxes. But a not-for-profit, trust me, you have to make enough money to ensure that you have financial viability going forward. And it's like, I couldn't believe that. And that individual had been in healthcare for years. Now, granted, working for Blue Cross Blue Shield for years, but for them to make a comment like that, it was just almost mind-boggling for me. But there's going to kind of wrap this up. Hopefully you'll get something out of this. And remember, the questions, again, I haven't written the test, but the questions, I'll write it probably this weekend, but the questions are, for the most part, going to be taken from the information in this video, information especially in some of the other videos, which I hope you're watching and commenting on, because the notes, Dewar's text, Arrow's article, the videos, all of that information pulled together is going to drive not only your quiz number 1, but your midterm, quiz number 2, and the final test that you have. So hope you enjoy this review, and hope everyone does well on the test or on the quiz. Talk to you later.